Thank you. Now it's my pleasure to introduce our next speakers, Courtney Kuepper and Jen Johns. Courtney is a social worker and mama of three with a passion for perinatal care. She's a member of the integrated behavioral team at the Family Medicine Center, an outpatient family practice clinic and medical residency in Fort Collins. Courtney's a leader in pediatric quality improvement and the behavioral health lead on the Integrated Care for Women and Babies project at the FMC. In 2025, she was awarded UC Health's Ambulatory Social Worker of the Year for her leadership in integrating plans of safe care in the prenatal outpatient setting. Jen Johns is an experienced social worker with 10 years in integrated health with a particular focus on low barrier care for patients with substance use disorders. She also teaches residents and about perinatal SUD care, as well as handles case management. Jen is the behavioral health team lead for the Family Medicine Center's Substance Use Disorder Clinic. And currently, Jen is involved with the Integrated Care for Women and Babies grant, advocating for comprehensive and accessible care for high-risk and perinatal populations. I'm really thrilled that they're here sharing their very innovative work. I think what you will hear is really different than what we've heard before in terms of work happening in birthing hospitals. And it's really from their efforts that we at Chosen have learned a lot about how we can implement plans of safe care in very specialized populations. Thanks.
Hello, everybody.
We'll do our best to bounce back and forth here on the mic as we chat.
We have loads of notes that probably didn't get uploaded into our... Okay, so thanks for having us. Like Dr. Wang said, I'm Jen, and this is Courtney, and we have been doing these plans of safe care for about a year at the Family Medicine Center. We're going to talk a little bit about engagement, what a plan of safe care is, and how to do one, our inpatient, outpatient process, a little bit of data. Courtney wants to make sure that everyone, she wants to assume, she's under the assumption that everyone knows how we got here in terms of federal mandate and the Colorado state implementation. If too bad, just kidding. What she said, this is her note. She says, if not, talk to her after. We usually have that included in here, but then, yeah, but like, you know, it is interesting, but also we've got other things to talk about, like how we're actually doing it on the ground. Okay. So the Family Medicine Center is an integrated clinic. We have integrated behavioral health. We have all kinds of different resources under one roof, which makes us particularly well suited to implement plan of safe care. We're responsible for doing all OB intakes, both high risk, low risk, mid risk. We serve primarily Medicaid patients, both general patients and our OB patients. Patients are often very comfortable at Family Medicine Center. We say it's a cradle to grave facility. And so that's another reason why we felt like, whoever, you know, people thought we were very well suited to pilot this plan of safe care in the perinatal period. It's her. We have had a substance use disorder clinic at a separate sort of like an ancillary clinic for about 10 years that has gone through multiple iterations, which also just sort of adds to our availability for patients and sort of wraparound services.
So we our prenatal work is a huge part of what we do at Family Medicine Center. We are one of two clinics in Fort Collins that accept patients with Medicaid for prenatal care. So we get quite a few of them. So 425 prenatal patients since July through July received care with us, which we think is quite a few. We also see all patients that are incarcerated at Larimer County Detention Center that are pregnant. So that is a really lovely place to meet people at and build those relationships. And hopefully they come back to us when they are no longer incarcerated. A behavioral health provider is the very first point of contact for all of our OB patients, unless there's an acute medical need. So they see myself and my coworkers, Leslie and Margie, the very first thing when they walk in, whether they're coming to us at 10 weeks of pregnancy or transferring care or late to care, whatever it is. They get to hang out with us for 40 minutes, which is pretty unique, very special that we get to build that relationship. We do a full psychosocial intake, a lot of relationship building. In that, we are doing universal screening for substance use using the 5 Ps. So that's assessing for past use, present use, peers, partner, parents. There it is. Got them all. And there's also a cannabis screener built into that as well. And that's consistent with what our inpatient hospitals are doing. So they can see we put it into a flow sheet and they can see it in the inpatient setting as well. They're doing universal screening at Poudre Valley Hospital as well using that same tool. We do universal screening for IPV, lots of resource referral, really anything that comes up, and that runs the gamut of things. And those conversations are always different based on the person. And then we continue doing OB care management throughout the pregnancy. That looks very different depending on the person and their needs. We are doing, through the integrated care for women and babies, we have a contingency management program for patients that have active or historical substance use, where they can get lots of goodies, and we get to be Santa, and it's the best. I love being Santa. And that just looks a little bit more intensive, more of these like regular long check-ins versus just popping into a return OB visit. So our goals of care, I got to switch it on here too. Goals of care with all of our patients, as we're working with pregnant patients with substance use histories. We're coming from a harm reduction, trauma-informed care perspective, definitely our guiding principles as we do plans of safe care work and as we build these therapeutic relationships. Here the font got Kelly. It's all right. It's all right. We'll forgive you. Our font got a little wonky. And Jen's going to circle back and talk more about that as well. So here's generally in the presentation where I add in these really beautiful slides from Support Colorado's work regarding federal mandate for plans of safe care, Colorado's implementation of plans of safe care, what that has looked like, reviewing our changes to child abuse and neglect reporting requirements that happened in 2020. So this is the part that we are skipping over for this presentation, but is really lovely information. So yeah, I'm happy to talk about it all day long if you want. Shannon right here up front, also a wealth of information, or just like ask a buddy to be like, how did we get here? What is happening? So a plan of safe care. It is a documented plan. It is a piece of paper in theory. What Jen and I always say is we refer to it as a framework for conversation and a guide for relationship and for these psychoeducation pieces that we want to hit during the prenatal period. Always happens collaboratively with the parents or caregivers, any collaborating professional partners, agencies. We will go over what the plans look like. So that is one thing that is that we'll review in just in a few minutes of like, what the heck do these actually look like? Plans of safe care address health, support, and substance use treatment and needs of the affected family. It shows off strengths and identifies areas where they need support and connection to resources. So we're doing these in the prenatal period, which is not at all required of us by federal mandate or by state law. It is just us feeling like they are really helpful and can guide our relationship and our conversation in that prenatal period, and can go with them to the inpatient setting. Big takeaway here. Boop. Y'all, okay. Plan of safe care does not imply child abuse or neglect, and having a prenatal plan of safe care does not mean that families will not be referred to Child Protective Services after delivery. So 2 really big takeaways there. I think this is you. Oh no, this is me. When do we offer a prenatal plan of safe care? So like I said, we are really capturing a lot more than what is required by the state, right? So requirement is that infants that are exposed to substances in utero should have a plan of safe care prior to discharge from a medical provider. Health systems are working on that one. But any referrals that are screened into CPS need to have a plan of safe care as well if they're screened in for further assessment. So we're really catching a lot more than that by doing these prenatal plans of safe care. So we are offering them as these things: an active substance use disorder, history of substance use disorder prior to learning of pregnancy with plans to abstain, are in recovery within the last 2 years, receiving MOUD or MAT, or continuing to use substances through pregnancy. These are just parameters that we set up to guide our work and our offerings. If a patient feels like they would benefit from a plan of safe care, we would certainly offer that. And the 2 years is really just a yes for those reasons, and just to kind of limit our scope a little bit. We are more than willing to offer if we feel like it would be helpful. Yeah. You ready?
Susan asked that we also talk about how we do this. And I said to Courtney, I was like, well, I mean, we just have like a lot of experience going into rooms a little bit blind with like a little bit of information and creating relationships. I don't know. Many people are good at this. It feels like particularly social workers, I think, feel particularly good at this because we get like a little bit of information and it ranges from like not acute to like very acute. We're like, okay, we got a little bit of information. What can we help you with? But I was like, let's break this down a little bit. We really approach it from a trauma-informed perspective, a trauma-informed lens. And I put the little turtle on there because it's slow. This is why it's lovely if we get a patient early, but that's not always the case. But even still, delivery of information and delivery of services is still, sure, there might be, like, we might need to expedite some of this, but it also still needs to move slow, and it needs to read the room. So because we saw this opportunity to meet patients before they deliver and have the opportunity to keep patients coming to visits, we have time. I realize again that there are a lot of things that we need to do prenatally. At least that's been our goal, right? That's been our goal. So we acknowledge that patients may have experienced trauma and that these experiences influence their responses and engagement. We do it from a strengths-based approach. I really go in believing that like the patient is the expert on their care and life. And I mean, I like believe that. And I had to do work, right? Like I had to like dig in and believe this. Not that I didn't believe this, but you know, my biases come up and I recognize them. I honor those. I really say, oh, I'm having a feeling. And you know, really working to avoid re-traumatization. I think this is also like the beauty of moving slow is that, you know, at these OB intakes, they get an enormous amount of information. And so adding on another thing, although I think that it's a really great resource and a really great thing to do, I need to like present this slowly and in a way that is patient-centered, strengths-based, and like trauma-informed. So I also believe in empowerment and collaboration, involving clients in decision-making, respecting autonomy, and fostering collaboration. I am like identifying this before I go into the room, right? Like I am really saying like, I'm not the expert here. So, let me elaborate. I accept, and when I do trainings for residents, I say like, if you leave with nothing else, leave with this belief that we have all experienced some form of trauma. Use that lens. Know that like we are all human. And regarding this, and as somebody who, you know, sort of manages our SUD clinic, that we accept that substance use disorder is a chronic health condition influenced by genetics, environment, mental health, and it affects the brain. Like we are treating a disease, right? I realize that I'm preaching to the choir, but like this is an absolute necessity to believe to do substance use disorder work. The crux of our approach is a focus on a person's humanity. We talk about substance use disorder. We talk about history, but from a trauma-informed lens that looks like slow and steady conversations about history, goals, successes. Oh my God, I wrote a Spanish word. And tristeza and sadness. Wonder what I was thinking there. Prioritizing safety is equates to autonomy, informed decision making about use. Like, where are you? Where am I meeting you? What are we working with here? Focus on long-term safety management, which includes offering insight about systems. Like, what questions do you have? What questions do you have about the hospital? What questions do you have about DHS? And rather than insisting on immediate abstinence, support safer use practices or gradual reduction, recognizing that any positive change improves health outcomes. Accountability without termination builds trust and safety. It's an honor to be part of a patient's journey. So, this is the kind of thing that, like, you can say to somebody, like, we say this with OB patients, but we say this in our SUD clinic too, like, there is very little that would mean that you can't come here for care. And I don't know, I feel like it sort of comes up naturally in conversation, but it can also be something that you can, like, literally say to patients. We're going to offer education on safer substance use practices, avoiding using alone to reduce overdose risk, use of naloxone. We're going to provide comprehensive, unbiased information about risks and benefits of substance use and cessation during pregnancy to empower informed choices. And creating an environment where a patient hopefully believes, because I believe that, like, the patient is worth helping and finding resources for. We do have to work together, though, through shared trust, and that takes time. Accepting that return to use does happen, reducing barriers to care. We've got an SUD clinic in-house and specialists. This is something that we have, like, an active thing that we do. I mean, I feel like those things just sort of, like, have happened. And this is something that we've really worked toward, is moving from a historical approach to a new approach. The historical approach being very familiar. I mean, this is the kind of pushback that we have gotten, is that changing is hard, right? And doing the familiar is easy. Like, we all understand this, right? Change is hard. No one likes it. We don't like it. I don't like it. But the familiar being testing focused, reporting focused, it feels like due diligence. It feels like that's what I'm supposed to do. But it also doesn't provide nuance. It's not patient-centered. It exacerbates stigma. It harms relationships with providers. Where the new approach is, we are universally screening. We are testing when appropriate. It is patient-centered, highlights strengths, and it is collaborative. It continues to ensure safety, right? Nobody is denying the importance of safety, both for the dyad, right? We want to make sure that all parties are safe, accounted for, and make it through. We're addressing substance use disorder. Like, we're having direct conversations about it and coming up with a plan together. We're utilizing resources appropriately and developing trust and openness. So, the new hospitalization approach, and we can share this with patients, right? Like, if patients are, like, on their second, third, fourth pregnancy and or new, right? People hear through the grapevine, right? Like, this is what happens at the hospital. And this is, like, where we sort of wanted to develop this, is that we wanted to improve the transition, or we wanted to improve relationships and the transition between the outpatient and the inpatient, because we do tons of work and we spend a lot of time with patients in the inpatient setting is when patients come back and they're like, oh gosh, it really fell through the cracks. That is saying it lightly, right? So, if you're in Colorado, you know that now we have universal screening with the 5 Ps, toxicology testing when appropriate, consent for tox testing, and affected by and threatened by assessment by the social worker. If this makes you feel uncomfortable, we go back to the slide before, because the new approach may make you feel uncomfortable, because you are going to have to use clinical judgment and not doing automatic tox testing, cord stat, based on a sort of, a quick review of a patient's chart. Oh, you're going to do this? Aren't I?
Oh, apparently I am. I'll give you a break. So these are what some of the templates look like. So this came out of really amazing work done by Support Colorado. These templates are being used all over the state. This one here is a brief piece of paper. Again, we will definitely echo that sentiment from a previous presentation. It's so much more than what is on this piece of paper. And this provides consistency, right? And a really lovely way for folks to document all the hard work that they've been doing. And in our case, that they've done prenatally. So the brief one is what, yes, early development of service and support plans. It's 4 pages. It's real quick and easy. That's what it looks like. There's also a comprehensive plan. So this is what DHS is using exclusively. It is 18 pages long, being used statewide by child welfare. It's a lot more comprehensive. Obviously, we have 14 more pages in there. It's full of such great information. So if you are, I would definitely encourage you to look at both, and I will have a QR code where you can find them in just a moment, and see which you think would better serve the families that you're working with, serve your purposes. For us, we started with the brief template. We were just handwriting them with patients. They were writing them. We were writing them. And then we would give the option to scan it into their medical record if they wanted it to go with them to the inpatient side. It was a mess. It was a very messy process, and it wasn't being utilized by the inpatient social workers. And that was a huge need that we saw to improve upon, was that communication with the inpatient social workers. Because again, Jen and I are working prenatally, and we don't follow patients over to that setting. They have different people with them. So we made our own little plan of safe care template that is based in Epic. This was created from templates that were originated by Dr. Lauren Bruns, who was here. There she is. Oh, she pops up. So I essentially just took that and kind of smushed it into our purposes and made it a prenatal plan of safe care. And this is a real one from a patient, so you can see some of their supports that they had in place. Yeah. And if we need to update it, so we can start working on these at any point during the pregnancy. And then if the inpatient social worker wants to update it, or if our nurse navigator at an antenatal consult wants to update it, we can add in those things as well. It's a pretty easy way to find it in the medical record where that paper copy wasn't necessarily. I have had patients who don't want it scanned in, and that is totally cool. And they would carry it with them, and they're like, here's my plan of safe care. And they just wanted to keep that hard copy. So we support people wherever they're at.
Live document.
It's a living document, so it is adjustable. We add to it as needed. And take away or whatever. So this will take you to the state's website for all things plans of safe care. The templates are on there, scripts on how to introduce it to the folks that you're working with. We give anyone who's working on a plan of safe care gets this handout here on the right. Really lovely, lovely stuff that everyone has done. Good. I don't see any phones in the air. Oh, there's one still. Hang on. I want to make sure everybody gets it. If not, you can just Google CDHS plans of safe care and it'll come up for you. So we start from a place of autonomy and consent, and kind of what I was referring back to. If a patient doesn't want it in their chart, we don't put it in their chart. We definitely want consent if this is being copied over to the baby's medical record once they are earthside. There are things in the works with the people that be in Epic gods creating a way for this information to copy into baby's chart with the birth person's consent. So both of these little snippets, the top one is from the template, and then the bottom one is from our Epic note, and really just driving home the point that the person that's completing this is in charge of the process. And I'll just go through these really quickly. This is The one on the left is from an EMR. This is the most beautiful plan of safe care I've ever seen. It was done by my colleague Margie with one of her patients, and I just thought I got teary-eyed when I read it because I think that they did such a great job together, really highlighting this person's resources and strengths, and she did such great work during her pregnancy. And I think that this really shows that off. And that's like the goal with the plan of safe care, and that she was able to take this with her to that inpatient setting and be like, look at all this stuff that I've done to her medical team is just really, really cool. So the one on the right is one that I think is the very first one that I ever did with somebody on the paper copy. But when we're looking at plan for myself, we're talking about the birth person. We're looking at their medical care, if they need treatment, if they want treatment, do they have therapy? Do they want therapy? Peer support is huge. We have an integrated peer at our clinic named Leanna through the Recovery Coach Doula program. So we are pushing hard for her involvement in things, and patients love her. And it's like our very first resource that we offer. She does incredible stuff. Then we're looking at plan for our family. We're assessing needs for community resources and referrals and goal setting and all of that lovely stuff. What I do like about the hard copy is that it has a place for goals. And that's something that Jen and I are having in our conversations, but isn't necessarily in that EMR template. But I think that that's really lovely that was built into these templates, because that's what we're really focusing on, right? Is what do you want? What are your goals? And you can't see this one on the bottom right super well, but you can kind of tell there's like a different ink. So living document, right? One of the big goals for this family was to get housing. And a week before she delivered, they got housing, which was so cool. And so I was like, we have to update your plan of safe care. And we like crossed it off together and wrote done on the goals and like filled that in that they got safe housing. So that was really neat. And then we look at plan for my baby. This is very forward thinking. Whereas if we're doing plans of safe care once baby is earthside, it's going to be a lot. I mean, baby's there, right? So we're planning for the thing right in front of you. This is really just like anticipating needs. Where do we think baby is going to go for their medical care? What are we talking about in terms of car seats? Do they have that? What are you thinking for a safe sleep space? And as we're going through this, there's so many points for psychoeducation, which is a slide in a couple of little bits, but we're not just saying like, do you have a crib? We're saying like, let's talk about safe sleep, and it's a part of that conversation, right? Or sober caregiving, whatever it might be. So the household members and supports is only on the comprehensive form, but we added it into the EMR version because we just like it and think that it's important to think about not only who's in the house, but other safe and sober caregivers that are available that, can care for baby once they're around. So we definitely talk about that. And this is our goals of caregiver psychoeducation. So this is also just the comprehensive plan there on the right. We have a table that's built into our EMR that touches on this prenatal psychoeducation. And these are things that we are trying our darndest to hit during that prenatal period, whether it be in just 5-minute return OB visit or a sit down in our office where we get to chat for an hour. But these are some of the topics that we are trying to discuss. Touching on safe caregiving, and then also like hospital policies and practices, because there's so many questions around mandatory reporting policies and what will that look like, and how long is my baby going to have to stay for and be observed, those kind of things. So when we say, again, framework for conversation, like this is the crux of it. Like this is the good stuff that we get to in those conversations. Do you want to start by this? Sure. It's you. I just get rolling and,
So like we described, a big goal for us was to improve the transition and then the transition back from outpatient to inpatient. And we've gone through a number of iterations to make our involvement known, / most of the inpatient folks know. I mean, we have meetings over there, but there's a lot going on. So there are lots of very overt indications that we are involved. It is in the snapshot. So if you use Epic, you know that the snapshot is the first thing you see when you go to chart review, right? Top left. Our name is on there. Estimated due date. How do you get in touch with us? Patient FYIs in the birth center alert. What? Oh, those ones, yeah. Both, right? But just FYI. And it's in the problem list, and we've come up with like our own sort of categorization where for a while it said ICWB, but as we like transition to not having that grant, we still want it to be very apparent that we're involved. And so we put it under complex care coordination and call it plans of safe care. We have told and discussed and shared all of this with inpatient folks because again, what we want to happen is a patient goes in and the inpatient team looks at it and they're like, oh my God, there's so much to learn here. I'm so excited to read your plan of safe care. Again, we're looking at like increasing conversations and increasing therapeutic relationships. We continue, here we've got areas of growth. We continue to work and need to, this is not perfect, I guess is what I should say. This is not perfect. Things fall through the cracks. We still have patients come back and say, we talked about this happening, not happening. And of course, we always preface things by saying we don't exactly know what's going to happen, but here, let's talk about possibilities. Patients are hoping for the least amount of information or intervention, and those things happen, right? So I continue to have a goal of like wanting to be more involved on the inpatient setting. I mean, literally we're situated across the street from the hospital. And at first I was like going over there post-delivery and sort of like intervening. I mean, I love going over to the hospital and meeting with the postpartum patients that I've worked with, right? Like I know them very well and I know the inpatient team. But then our numbers increased and that was hard. But yeah, so this is where it is. We wanted people to see this, like we don't want it to fall through the cracks. We have tried to make it as obvious as possible. Please ask questions about that. This is like one of our main takeaways, take homes. What happens to the plan of safe care? As we've discussed, it can go into the EMR. Most patients prefer that, right? Like it's kind of silly to have a piece of paper, although some people like to have like a little folder because we hand out a folder with all the information. They like to put it in there. But most of the time we're like, can we please put it into the EMR? Are you comfortable with that? Or they have a hard copy. We don't care. We don't care. And as discussed, inpatient social work, inpatient OB can review it. I don't think they are, but social workers certainly are, and the nursing team is. If there is DHS involvement, caseworker only needs to review and revise. Okay, I think we need to, you want to talk about this one?
Sure. So going back to our slide, talking about 425 prenatal patients, July through July. Of those, 126 screened positive for substance use, either present or historical substance use disorder, and that includes cannabis. We have done 41 prenatal plans of safe care. That is within, I guess we're almost at 12 months now. I think the first one I did was mid-November. So those data points are a little bit off. We just offered a survey to our patients, so we wanted to share that with you all of the 41 who have received plans of safe care. It's a pretty informal survey, but here are some of the things that came back. Really overall very positive. I understood the plan of safe care. Everyone agreed or strongly agreed. We got 16 responses, which I felt like was pretty darn good out of 41. And a lot of those bounced back to me. So I feel like that was a pretty good response, right? We're going to continue offering that as well. As people continue to fill them out. I felt included in making decisions about the plan. Everyone agreed with that. My needs and goals were respected. I felt judged or stigmatized during the process. We did get one agree on that. So room for growth. I'd like to see room for growth though, right? We're definitely not doing everything perfect. And that's good to know. And plan of safe care helped to reduce my stress or anxiety. We got a lot of agrees and strongly agrees on those. And these aren't the only questions that we asked. We asked quite a few more, but these are the ones that we just wanted to highlight in this space. And then quotes, because I just love quotes. I was just living for these as they were coming in. I thought it was so, so lovely. So I like the fact that if CPS tries to get involved, we already have a safety plan before they try to be involved. I like that it helped prove my sobriety so DHS wouldn't even bat an eye at me, and also show how much support I have in my recovery. A lot of themes around not being judged, support, education, confidence, security. These are just some of the ones that we got. So I thought that was really, really cool to share with our team. And then we asked, would you recommend the plan of safe care process to another parent? Everybody said yes, which is cool. This is really cool. Everybody. Or maybe, yeah. And there's just some additional quotes that when we asked, like, do you have anything else to say? So I just love that it's keep doing this for other moms, continue this program. And I love that helped keeps me motivated. I thought that was a really neat one too. So very cool. So we also have pending data coming, provider-based, just very exciting stuff. Kelly Nash, who I know is here, she might be outside, with Chosen, has helped compile some really great qualitative interviews. Myself and Jen did those, medical provider with FMC, a couple inpatient social workers up in the Northern Colorado UC Health hospitals. We also did a survey that went out to everyone at FMC, both medical and behavioral health providers. And then we've done a couple of different presentations on plans of safe care up in Northern Colorado, and it was offered to that as well. So much data to review and parse through, and we're all just very excited about that. Here, and on the bottom is just some themes that came out of those interviews that Kelly did. So just a little teaser, and we will have more to share on that soon, I hope. So, and that's me and Jen doing yoga. We really love yoga and doing it together, and that's us. So thank you. We'd love to field questions too, because I know it's a big topic.
Thank you so much. What I love about their work, so many things that I love, but what I love is that when they started, there was this big thing, right, that they were trying to do. This is the federal mandate. This is how we do it in Colorado. This is how our county does it. So many layers to think about. It can be so complicated, but their team just said, we're going to do it now in this smaller scale. And you all made it manageable for yourselves. You said, well, there's no way to record it anywhere or transfer, so we're just going to do it on paper. And we're going to just pass the paper, right? So most people would be like, maybe you should have put some more thought into that, right? And make things so complicated from the outset, and then nothing happens, right? And so how do we think locally? How do we think simply to just make something happen? Because you knew that care could be better. And it's iteratively over time, then you figure things out. You get more feedback, both from providers as well as those with lived experience, and then you adapt. And then things become more systematized, as you have shown through EPIC. So I love that it so perfectly illustrates what a quality improvement framework can lend to this type of work. And clearly you've operationalized it. So I think it's so exciting. And the fact that it's under the outpatient family medicine umbrella, I think is a very innovative approach that we haven't really thought about within the Chosen Collaborative. All right, with that, let's open it up for questions. All right, I'm going to get us started. So you talked about, going from outpatient to inpatient. What happens when there's a new patient that shows up as inpatient, ends up being within family medicine, and then they go to outpatient? What does that plans of safe care process look like? There was no prenatal engagement. It all started at birth and then has to continue thereafter.
Yeah. So because we are a residency, our residents are doing our deliveries at Poudre Valley Hospital. They also do the deliveries for the federally qualified health center up in Fort Collins, and for any of these folks that would just come in to have a baby. So it's really lovely process, because then they can build that relationship with those patients when, like, Jen and I aren't there, right? But our residents are, and they're delivering those babies, and they can have a really positive experience, and then hopefully loop that person into coming for postpartum care and to bring their baby to us too. So that, I think that that's the beauty of family medicine, is that we are able to kind of have that loop. So even if we are only touching them inpatient, they would transition back to us either for baby's care or for their postpartum care. And in those situations, we hope, and I definitely have had the inpatient social workers say, like, hey, so-and-so just showed up to deliver. The residents are trying to get her set up with, postpartum care at your clinic. Just wanted to give you a heads up. So there is that communication.
And I think regarding a plan of safe care, the hope is that through our involvement and I guess best way to describe it, training, is that the inpatient social work team could also do it. I mean, here they can, but we have long discussed the barriers mostly related to time, right, and capacity. But the hope is that this short version, which really doesn't take that long, especially in this scenario, that they could do that and then send it, if DHS gets involved, they've got it, they can send it back with us so we can follow up on goals and resources needed. I think that's the ultimate hope and goal.
I think it's on. Okay. Ann Borders again, ILPQC. This was so inspiring. I took pictures of every single one of your slides. But I was wondering kind of closely what you were just talking about is like you guys are doing this like amazing program in the prenatal space where you're building trust. You're having these really motivating behavior change conversations. You're documenting it in this really positive way. You give people this roadmap that says like, you're on this journey to recovery and we're here with you, and look at, these are all these supports. How do you, and then they go inpatient to deliver and they're interacting with all the inpatient staff and inpatient folks and potentially someone, DHS, and potentially someone's interfacing with that report or that plan that you created. How did you guys engage the inpatient space to help them move into that same sort of space with you? Because you're creating these really positive experiences for patients where they feel like they have a care team who's really caring for them. They're doing shared decision making. Is there ever, or was there ever like a breakdown where someone goes in and they're like, I was treated, I was judged, they didn't listen to my plan of care. No one looked at it. No one knew where it was. I'm not like, how did you interface with the inpatient team to help them stay a part of the team so it felt like there was kind of contiguous feeling of care? And we tried to do in Illinois where we had a group doing a lot of what you guys are doing. And then they tried to set up inpatient meetings for patients where they would have someone from the outpatient team on a call, and they would do like a care plan meeting before the patient with substance use sort of showed up, and maybe the patient would go tour the NICU, and they would and there was sort of kind of trying to create a coordinated, like, we're all on the same page. What if you guys have done anything like that, or how you've engaged the inpatient space so it feels similar to the patient, to what the amazing stuff you guys are doing?
Yes, I love this question. We try our darndest to build relationships with the inpatient social workers. We meet with them regularly. This is definitely the point that we are at in this project, is like integrating this into the hospital system and getting people on board and really capitalizing on the excitement around it. And if there's any champions around plans of safe care, looping them into the work. We recently, in August, did a training for Northern Colorado hospitals on plans of safe care. And so that really trying to just like get the word out, get people interested, and see what this is, what it can look like on the inpatient setting. And some of that we run up against a wall, Jen and I do, because we are social workers at an outpatient clinic. And there's only so much you can do within a big health system. but we try our darndest with that. Lots of advocacy, lots of relationship building. I think being able to, for our recovery coach doula is huge, being able to go into that inpatient space with patients. So like we will all work together with the patient and then she gets to go with them and be that advocate on the inpatient
do you-
space. That's huge.
How do you get the clinical providers? So you're the clinical team, the neonatology team, the OB or the residents, your learners, like how are you bringing them along into this trauma-informed care space? What a plan of safe care, why? How do you, it's like we need to replicate all of you and like put you on all the clinical team shoulders, but like,
Yeah.
how do you do that?
Well, I think for for residents and our team, which delivers a majority, a majority of the babies at PVH, they are all on board. We've been talking about this for over a year, right? We do presentations at all provider. We do presentations at all staff. We talk about it with residents when they have a patient that needs, additional support. So they are familiar. So that's one piece that is like pretty tied up. Well,
Our medical provider.
yeah, our like at the Family Medicine Center. I would say there is another medical group, an OB group, who have very little idea. Even though they rotate through for our prenatal clinic, they likely don't know. So we continue to work. I mean, we're in this unique situation that we've got this really cool grant, which we wouldn't need the grant, but it helps to provide food and pay for people to come. Where we're working to like bring people up to speed. It's just slow.
Yeah.
Slow.
Certainly an area of focus, and I
Yes.
think Dr. Borders' presentation, I'm sure will give us some ideas how to better engage maternal providers on the obstetric side of things. Thank you so much.
Thank you.